Good evening, everyone, and apologies for the delay and the late start. We were having some technical issues. That's actually the first in the last 3 years that we've had a delay, but I guess it happens. For those of you who are new to LEJEndo is a monthly endometriosis journal club that is run by the CEMIC team. Oscar has now taken over from Flo in running LEJEndo. So welcome to Oscar.
Thank you very much.
And tonight we have a special guest, Rebecca Malik, who's our friend and colleague, and has been a friend of CEMIC for a long time, and is now the Vice President of the British Society of Gynae and is our special presenter. We don't call it special presenter. What do we call featured presenter? Yes. A couple of notes. One is that the session will be available online on YouTube. Most people go there and look at the previous sessions, and I invite you to do that. Subscribe, join, ring the bell, that kind of thing. The second thing is to say, particularly to our audience who are not medical professionals, that what we present here does not necessarily represent our opinions. And that's how evidence-based medicine works, that we look at different views, different angles, and some of those we think should be translated into clinical practice. Some of those will need more information before we do that. So don't necessarily assume that what we say here is the latest and the best evidence. So with that in mind, let's start our small article presentations. Who's first?
It is Avril, but she's just having problems with her laptop speaker. So Oscar,
Oh, technology.
Hopefully you can see that.
Yes, we can.
Lovely. So this is you then, Flo, is that right?
Perfect. So I'll start with this paper. This was published in PLOS ONE in April this year by a group based in Rio in Brazil by Crispy et al., looking at the follow-up of bowel endometriosis resections performed using the double circular staple technique. So this is actually just an observational study. So whilst it's not considered high-level evidence, it is one of the largest and longest follow-up series for a double circular staple technique, which is actually very limitedly published limitedly in the data, limited published data. It also looks at functional outcomes, it looks at complications, and I think actually reading it, it was really nicely written. It's got some nice diagrams, which I'll show you. So I thought it'd be an interesting technique to go through. So a little bit on background, as we know, deep endometriosis of the bowel managed surgically in 3 ways: shaving, discoid, segmental. And a very accepted school of thought is to do the most or the least invasive option, to remove all of the nodule, but whilst preserving as much of the nerve innervation to the bowel as well as vascular supply. So with that, the most invasive segmental is considered to be associated with higher complications and potentially functional impairment rates. So this group looked at the double circular stapler technique, which is actually the sequential use of the transanal stapler to remove one large nodule, and in doing so avoiding potentially a segmental resection. The aim of the study was to look at the early and the long-term outcomes for this surgical technique. So it was a retrospective observational study carried out from 2010 to 21. It was done in Rio in the Crispy Institute, which is a private minimally invasive unit. It included 43 women that had erect sigmoid deep endometriosis suitable for this double circular technique. The primary outcomes were looking at perioperative complications. The secondary looked at bowel, urinary pain, and they also commented on fertility. The follow-up was varied, but median time was 36 months postoperatively, and they also looked at functional outcomes, which were assessed with validated bowel and bladder and pain scales. So if you just look at the flow diagram on the right, you can see, as we know, just with serosal or superficial muscularis involvement, the nodule can be removed with shaving, but with deeper involvement of the muscularis, for those nodules less than 2 to 3 centimeters, a normal single circular stapler is used for a discoid resection. But they suggest that those nodules between 2 to 3 centimeters and 4 to 5 centimeters can be removed with a double circular staple technique. And as we know, larger nodules, 4 to 5 centimeters and bigger, and also the multifocal lesions will necessitate a segmental resection. So these are the nice diagrams that I mentioned, just showing that surgical technique. So this group used Ethicon 33mm CDH stapler, and you can see it being introduced into the rectum there. They used an anchoring staple suture. They used a Prolene suture at the proximal end of the nodule and passed that through into the center of the nodule. And then when they opened the stapler, which you can see in image 3 onwards, they used that anchoring suture to then drop the bowel nodule into the open gun, and then pulling the sutures laterally around the mobilized rectum to make sure that all of the nodule is incorporated into the stapler before it's fired. They then remove that disc and then reintroduce the stapler, either again with the 33 or sometimes they will use the 29 for the second. They place another anchoring suture. They say they place it 1/2 to a centimeter proximal to the staple line, and then 1/2 a centimeter distal to the end of the bowel nodule. Open the stapler, drop it in, and then fire it again. Also, what they do, similarly to what Mr. Ghazali and Mr. Karim do with the discoid resections, they do a figure of 8 suture at the staple line to reinforce it, but they also use a biological fibrin glue, which I hadn't come across before. They do an air insufflation test. Interesting, none of these patients had abdominal drains, and then post-operatively they were put on a liquid diet for the first day, had bloods post-operatively, and then the average length of stay was 5 days for these patients. So you can see on the right, of the 1,150 cases in that 10-year period, there were 45 that were or fitted into that category for the double circular staple technique. One of those were lost to follow-up, one ended up with a segment. So that left 43 for this study. So moving on to the results, as I said, this is observational. There was no control group, there was no statistical analysis, and so they really just reported on those 43 cases. But of those, they were all minimally invasive, none were converted to open. They reported no anastomotic leaks, no transfusion, no need for an ileostomy or colostomy. However, within that, they did have one rectovaginal fistula. It was recognised on day 12. The patient had an almost 2-week stay in hospital, resolved conservatively. They did comment actually on this in the discussion. They said that actually this was one of the lowest joins that they did of the 43, and perhaps because it was so low when the stapler was closed, whether they incorporated some of the vaginal mucosa that led to this fistula was a possible cause. They had no long-term urinary retention, and as I said, median hospital stay was 5 days. Looking at the long-term functional results, pain improved 88 to 100%, increased in more than 3 points on the VAS pain score for dysmenorrhea, dysgeusia, dyspareunia, and back pain. Bowel function, there was one patient that reported significant worsening. Otherwise, they reported stable or improved function. Urinary symptoms were mixed. 28% reported an improvement, 26% were worsening. I think 5 patients needed a catheter for longer than a month following the procedure, but actually of all of the patients, they were all voiding without the need for intermittent south catheterization at the 90-day mark. And then with regard to fertility, 20 of these women tried to conceive, of which there were 14 pregnancies and 11 live births. So in summary, takeaways from this, this study shows or demonstrates that this technique is feasible, it's safe, and it may be a nerve-sparing alternative to what otherwise may have been a segmental resection. It suggests that it's suitable for lesions less than 5 centimeters, less than 40% circumference, and less than 25% of the luminal obstruction. Although it's a small population, a small number of cases, they report a low risk of leak or functional deterioration. But as I said, limitations, it's single center, it's observational, there was no control arm, and they just use semi-qualitative analysis. So take home, I guess in expert surgical hands, it may be a technique that can offer long-term pain and functional outcomes whilst minimizing complications.
Thanks, Flo. Well, that was the most relevant paper, really. It's addressing a question that we ask every day, that, is it safe to do double disc, maybe triple disc? And so that's really good. Do you know if they did any flexible sigmoidoscopy on them?
They didn't in none of them, but they did write in the discussion. They said actually there is a benefit of doing it to observe intraluminally
Yes.
staple line.
Well, as it stands, we have a patient on the ward, as Oscar will tell you, with double disc, and yeah, we did a flexisigmoidoscopy on her to confirm there's no obstruction. We're hoping she goes home tomorrow. Well, that's great. Thank you very much. If the others agree, I'm going to suggest that we go straight to Rebecca, and then we see how much time we left afterwards, and then we'll present as many papers as we can in the time that is remaining. Is that okay, everyone?
Sounds good.
That's good.
Perfect. Okay, Rebecca, I think I've done some of the introduction, but it's my pleasure to introduce Rebecca Malik, who's a consultant gynecologist and endometriosis surgeon in the south of England, not too far from us. And Rebecca is going to talk to us about the use of ICG, which these days is quite a topical improvement in what we do. So we, in our practice, use it on a daily basis and almost completely replaced methylene blue with indocyanine green. Let's see what Rebecca is going to talk to us about. You're on mute.
Lovely. Sorry.
Perfect.
Fail. First thing I failed at. Apologies. Now, thank you so much for the very kind introduction. I'm just going to go back a little bit. So can everyone hear and see the slides? Is that all good? Excellent. Thank you.
Yes.
So yes, thank you guys for this, for the invite, and it's a pleasure to come and chat to you. What I'm going to share with you really is the paper that we published just a couple of months ago in FVVO, and it's improving efficacy and safety of surgery in benign gynecology and the case for ICG. As Shaheen has already alluded to, quite a lot of people have introduced ICG into their practice, and it's something that I've been doing probably for the last couple of years, but there is a real paucity of data around it, and that was the main driver for doing this paper, was to do a systematic review of the literature and see what was out there in terms of the safety data, the protocols, and how we use it with a clear focus on non-cancer surgery. And so this is just a link to the article if you want to read it in full. And I just want to thank my co-authors, Bomi Kim and Ian Novell, who did most of the hard work for this paper. So what I thought I'd do is just over the next 15-20 minutes or so is go through the methodology of the paper, give you a little bit of a background to ICG and its safety profile, look at its clinical uses and all the evidence around it. We'll look at the strengths and limitations around the evidence to do with ICG, and then just touch on the future and the possibilities that it holds. So what we did was a systematic review of the literature. We looked at various different medical databases including PubMed, Embase and the Cochrane Library. We looked up various keywords, ICG, laparoscopic surgery, robotic surgery, endometriosis, and we included all papers such as systematic reviews, meta-analysis, trials, feasibility studies and case reports. The only articles we excluded were any non-English articles without any adequate translation and any articles on ICG that were focused exclusively on gynae oncology, as there's a lot of data out there around sentinel lymph nodes and we wanted to focus purely on non-cancer surgery. And the way that we presented this was a narrative review of the findings looking at the surgical applications of ICG. So just as a little background as to what is ICG. So I'm sure many of you who are watching will be using it in your day-to-day practice, and it's a medical fluorescent dye that has been used across a number of different specialties for many, many years now. It's used routinely in ophthalmology and cardiac surgery, and it's actually first licensed and used by the FDA back in the 1950s. And the way that it works is that when it's illuminated with near-infrared light, it emits a fluorescence, which is then picked up with specialist imaging equipment, so your near-infrared camera stack or robotic system. And that then allows visualization of vasculature in organs in real time. So when we're looking at ICG, the best way to subdivide it and how we then went and did our literature review was look at intravenous uses and look at direct installation as well. So when ICG is given intravenously, the way that it works is it binds to the plasma proteins within the blood, and that's mainly albumin. The key thing to note about ICG is that it has a very short half-life. It only remains within the system around 3 to 4 minutes, and it's wholly metabolized within the liver. The good thing about ICG is that when it's given intravenously, the vast majority of it stays within the intravascular component. So you get very little tissue absorption, which is excellent from a safety point of view. Another use of ICG is directly instilling it into organs. So from a gynae point of view, the two that we would use it for would be bladder and ureters. And the way that it works is that ICG binds to the active mucosal cells. And most of the studies suggest that it has a long duration of action and it can remain visible for 5 hours plus. And when we looked at the studies, it was anywhere between 5 to 12 hours of visibility with one application. So we then looked at the data with regards to safety. So is it safe? And the vast majority of data suggests that it is. There was one large the largest case series of ICG use looked at over 1,200 patients. There were no fatalities associated with ICG use, and there were only 5 moderate to severe reactions, and these were allergic reactions. You need to avoid it in patients with a known iodine allergy, and you need to be cautious in patients who have liver dysfunction because it's metabolized within the liver. So the recommended dose is significantly reduced. The standard maximum dose for ICG is 5 milligrams per kilogram, and if you imagine that the dose that, or what we use in the UK is Verdi, and that's one vial is 25 milligrams. So even if you're using a couple of vials of ICG in a patient for a number of different uses, you're not getting anywhere near that standard maximum dose. So to start using ICG, you need a laparoscopic stack with near-infrared technology. I use the Storz Rubina 4K stack and have found really fantastic image quality with it. You need a scope with near-infrared technology as well. If you're using robotic surgery, then most of the systems have near-infrared technology built into it. So the Da Vinci, for example, has Firefly, and then obviously you need your ICG as well. And as I alluded to, the most common brand in the UK is Verdi. So preparing ICG, and again, we looked at various different papers, looking at its efficacy and how long it maintained its fluorescence for. One vial of ICG, as I said, is 25 milligrams. It is usually from an intravenous dose diluted in sterile water in 10 mils, so you get 2.5 milligrams per mil. Ideally, it should be prepared immediately before use because it can reduce its efficacy if it's stored directly in light or at room temperature. And most of the studies seem to suggest that it can decline its fluorescence anywhere between 8 to 6% per day. So ideally, and what we would usually do is prepare it just before usage in a patient. If you're going to store it, then ideally it should be stored at around 4 degrees, so at a lower temperature, and protect it from light to maintain its efficacy. Now, what are the uses in benign gynecology? What I have used it for, and the main reason for doing this paper and doing this systematic literature review, is for bladder mapping and looking at bladder integrity, looking at ureters, and for bowel vascularity. But it can be used for a number of different reasons, and I'm going to share with you all the different data that we came across when we did this review. It can be used for cavity detection, in myomectomies, tubal patency, demarcation of the vagina, ureteric vascularity, ovarian vascularity, and there is some evidence that it can be beneficial in identifying endometriotic implants as well. So I'm just going to go through all of these, and I didn't want it to be completely dry and just share with you the data, so I've included some of my own surgical videos in this as well. So bladder injury, perhaps, well, it is not perhaps, but it is the most common visceral injury in gynae surgery, and unfortunately still up to 30% are missed intraoperatively. And there have been a number of different papers that highlight the benefits of using ICG as an alternative to methylene blue to help demarcate the bladder. And it can be particularly useful in those cases where they've had multiple cesarean sections, scar ectopics, knee surgery, etc., where you've got significant bladder adhesions and you want to see the edge of the bladder. Una and colleagues in 2024 described a nice washout technique where ICG is instilled into the bladder and then emptied out so that you can clearly see the green within the bladder, so you can keep it in view at all times and help with bladder dissection and colpotomy. The standard dose in the literature is usually 25 milligrams of ICG diluted in between 200 to 400 mils of sterile water, and it's given much like you would give methylene blue via a catheter and a bladder syringe. And it has some benefits over the standard modalities that we've historically used. Some people will use saline, but that can, and the studies have suggested, miss small leaks because it's clear, whereas with ICG, you're not going to miss those. And I'm sure you've all seen or used methylene blue, where you will use it for a dye test, for example, and it will stain the peritoneal cavity. With ICG, you don't get that staining, so it provides real-time visualization. So this was just a case of a patient who'd had 2 previous cesarean sections, and just we were using ICG to demarcate the bladder. She didn't have terribly much bladder adhesions, but you can see here we've given ICG, we've deflated the bladder, but it has stained the bladder really nicely. So you can see, and I'm pointing out here, we're doing some teaching, but you can see here it's where the colpotomy cup is, and you can see very clearly where the edge of the bladder is. And it's also really helpful at the end of the procedure, where you can see exactly where the bladder is, and you're not inadvertently going to catch some of the bladder in your suturing. Another use that's been described in the literature is filling up the bladder to stain it prior to excision of endometriosis, and particularly deep nodules. This patient had a mixture of relatively superficial endometriosis in her UV fold. So we filled up the bladder with 200 mils of ICG, give it time to allow the bladder walls to stain green. You then do your excision of the endometriosis. And you can see, once we move on a little bit, here we go, you can see the bladder is kept in view at all times. You can see the green staining of it. You know exactly where it is, and you can crack on and do your excision. What you can then do, and I'm just going to skip to it a little bit, what you can then do at the end of the procedure, and what we're doing here is just refilling up the bladder just to double check that there's no inadvertent leaks. So ureteric injury, and this is where there's quite a lot of data in the wider literature. We all know that ureteric injury carries quite significant morbidity for patients. And again, unfortunately, still around 70% are missed intraoperatively. And the more complex surgery one does, the higher the risk. Now, many will argue you can use ureteric stents. And there was a large case review of ureteric stents. In 2021, there was a review of over 50,000 cases, and it was associated with quite significant complications. You can have more minor complications like bladder irritability, hematuria, UTIs, loin pain, but you can get more significant complications like stent migration and ureteric perforation. And the evidence still doesn't entirely suggest that stenting reduces the risk of ureteric injury. So in general, it should be reserved for high-risk cases. And this is where ICG comes in. As I said, there is quite a bit of data out there, and it was actually first described by urology colleagues doing robotic surgery back in 2013, where they highlighted the benefits of giving intraureteric ICG to visualize the ureters. It was first described in endometriosis surgery back in 2015, and this was in the context of excising endometriosis around the ureters, and they highlighted improved lesion localization and improved surgical precision. Sadeghi and colleagues in 2014 looked at the use of ICG to identify the ureters during laparoscopic urogyne procedures, and they did a case series of just over 10 patients, and in all those patients they had 100% success in ureteric visualization, and reassuringly there were no intraoperative or postoperative complications. So the data does seem to suggest that using ICG gives you real-time ureteric mapping, and it may improve intraoperative safety, and it may reduce inadvertent injury. So this wasn't in our published paper, but we're going to be submitting this for publication soon. This is our own data with regards to ureteric ICG. We've done well over 50 cases now, but we looked at the first 50 cases because I wanted to look at also complications. Were there any complications associated with ICG? How successful were we? And how much time did it add on to the procedure? And what we found was that actually it was quite quick. From beginning of cystoscopy to end of cystoscopy, it only actually added, on average, 170 seconds. A guide wire was only used in one case to help catheterize the ureters, and we had successful fluorescence in 100% of cases, and throughout all cases the ureters remained visible throughout. And I think the longest case was a endometriosis procedure with an anterior resection that lasted around 4.5 to 5 hours. 2 patients had intraoperative stents as well, and that was purely prophylactic because of the amount of dissection that was done around the ureter. There were no intraoperative or postoperative complications, and there were no iatrogenic ureteric injuries. And the vast majority of the procedures that I tend to use it for are endometriosis procedures and some hysterectomies. So for me, the benefits really are, it allows transperitoneal identification of the ureters, reducing the need for opening up of the sidewall and subsequent fibrosis. If you are opening up the sidewall, it helps you identify the ureter and perform a ureterolysis. It reduces the need for formal stenting, so involving urology colleagues, x-ray, additional theatre time, cost, etc. And again, for me, it reduces operating time, but hopefully we'll be publishing this data soon with an objective assessment of operating time. So with regards to the actual technique of how it's done and what's been described in the literature, in the vast majority of cases, and this is certainly what I do, a 22 French or 25 French rigid cystoscope is used. In my practice, we use 6 French ureteric catheters. The catheters are only inserted into the ureteric orifices around 2 centimeters, and dilute ICG is instilled into each orifice. So it's 1 vial diluted in 10 mils of water and 5 mils instilled into each side. And these are just some images that you can see. These are just straightforward hysterectomies. I'm not advocating doing it for every single hysterectomy, but I do think in cases such as the one on the right, where the patient's had a couple of cesarean sections, or if they've got endometriosis surgery, it is a definite benefit. You can clearly see the ureters, you can keep them in view at all times, and it does, I think, improve surgical confidence, improve the confidence of trainees doing procedures as well. And it's never a substitute for knowledge of anatomy and being able to dissect out a sidewall, but it's a helpful adjunct. Similar videos here, which I will scoot through quickly, but it's just showing again here where we've given ICG into the bladder. It's dyed the bladder so you can see exactly where it is, but it also shows you on the left hand side when you're doing hemostasis. We didn't have any bleeding from the uterine pedicle, but you can see how close the uterine vessel is to the ureter when the tension from the colpotomy cup is taken off, and how it does potentially add intraoperative safety. This is just a case of a patient who had superficial and deep endometriosis over their pelvic sidewall, uterosacral ligaments, pouch of Douglas. So just doing a wide excision and butterfly excision. Again, it's not changing the surgical technique. You're still opening up the sidewall, you're still doing an excision, but it just allows you to keep the ureter in view at all times. It's particularly helpful for those ones where you might have had a little bit of bleeding into the sidewall, which you try and avoid, but if it happens, you can get a bit of staining, and you're constantly going back and forth, trying to see where the ureter is. Whereas when it's green, it's there at all times. And I think it's just an added safety adjunct. Similar case here, where we're doing an excision, just allows us to work very closely to the ureter. And again, this was a case of a patient who had, I think we did a disc excision, I think, in the end. From what I remember, she had a significant nodule of endometriosis on the bowel. But as with the vast majority of cases, it's not intrinsic ureteric involvement, but there's extrinsic pulling in of the ureter. And just ICG allows you to visualize it beautifully. You can see the path of the ureter. You know exactly where it's going, and it allows you to work very closely to it or around it. Now, other uses of ICG in the literature. There have been cases described of using ICG as an alternative to methylene blue. In terms of cost analysis, I think we do need more data around the cost of ICG versus methylene blue. However, I'm not advocating it could be used for all patients, but the benefits of using ICG over methylene blue is that it can be done at the beginning of the procedure rather than leaving it to the end to avoid unwanted staining, because you can do it at the beginning, you can avoid the false negatives, and you can switch off the ICG. And you can see that's actually what we're doing here. You switch it off, there is no staining, and you can proceed with your planned surgical procedure. Now, assessment of the uterine cavity. This is another use of ICG that's been described in the literature. We know that myomectomies are done primarily to preserve fertility, and the biggest concern as a gynecologist is reducing the risk of rupture when these patients become pregnant. And there have been a number of different studies that have looked at what are the risk factors for rupture. And a uterine breach is a potential risk. Data seems to suggest it's not necessarily the breach of the cavity itself, but it might be small inadvertent breaches that are not repaired that may increase the risk of subsequent rupture. And this is where ICG may be beneficial, because you can put ICG into the uterine cavity. It stains the uterine cavity green, so you can keep it in view at all time when you're doing your dissection, but you can also give an additional bolus of ICG into the uterine cavity via a manipulator and detect any small inadvertent breaches that will allow you to repair them when they potentially may have previously been missed. And I thank you again to the CMIG team who very kindly let me borrow this video when I presented last year. So I've kept this in for this presentation. I don't do robotic surgery myself, but this is a beautiful video just highlighting how they're utilizing ICG to identify where the endometrial cavity is during a robotic myomectomy, so that the cavity can be safeguarded and prevent the breach for the reasons that we discussed. A case that we did here, which was an excision of a rudimentary horn, and this was fertility preserving. So we're just doing a dye test. This was supposed to be a non-communicating horn, but this is just an added safety feature where we're putting some ICG into the cavity to double check that we didn't need to reinforce that side. Now, there have been other novel uses of ICG in the literature. Neem and colleagues in 2024 proposed injecting ICG directly into the pseudocapsule as a means of actually improving identification of fibroid borders that might improve resection of fibroid and potentially reduce blood loss. So an interesting and more novel technique. And Krentel and colleagues also described using ICG to demarcate uterine niches before resection surgery. They found that using ICG improved the visibility of the niche. They were able to see the resection margins better, and that then resulted in reduction of unnecessary adhesiolysis and subsequent bladder injury, the reduction of unnecessary hysteroscopic procedures, and they felt it improved surgical precision and streamlined their procedure. So there are lots of potential and novel, exciting kind of uses of ICG out there in the literature. Just case reports and case series at the moment, and as with everything new, more data is required. Another use is utilising ICG to identify vaginal mucosal edges to improve vault closure. Not something that I routinely do, but when we actually looked at the literature, it does seem to suggest that using intravaginal dye to aid suturing might reduce dehiscence rates of the vaginal vault anywhere between 0.64 to 1.35%. And I do have colleagues that use methylene blue, and ICG may be a safer, more cost-effective alternative to it because it seems to provide better fluorescence. So it can be particularly helpful during difficult hysterectomies, or, for example, if you're excising vaginal nodules. And there have been a few other uses of vaginal ICG. Menzies and Rao in 2024 utilised vaginal ICG by injecting it into the rectovaginal plane, and they found that it was helpful to improve real-time anatomical visualization when they were doing complex surgery. Sarafim et al. In 2023 utilised it in laparosacral colpopexy procedures where they directly injected ICG into the vaginal walls and felt that it really helped identify optimal dissection sites rather than the standard tactile guidance that is normally done in a laparosacral colpopexy. And again, the team at CMIG, it's a really nice article in FVVO as well, utilised the use of ICG to tattoo a vaginal nodule, and they found that it helped demarcate the nodule and the vaginal tissue better to facilitate a more precise excision and allow better preservation of normal vaginal tissue. So this is just a couple of videos demarcating this. This is, or highlighting this. This is a patient who had 2 or 3 cesareans from what I recall, and we put some ICG into the uterus and into the bladder, and you can see it had helped us do a bladder dissection, but we also put some ICG into the vagina just to really demarcate the vaginal wall. And I think you can see it does aid in suturing. It allows you to make sure you're capturing all of the vaginal vault and reducing the risk of potentially reducing the risk of dehiscence, dyspareunia, etc. This is a case of a patient who had a full thickness retrocervical nodule, and again we utilised intravaginal ICG, but just on a swab on a stick into the vagina to demarcate where the vagina is to aid dissection. So you can see the staining of the vagina is coming into view now. We can see exactly where it is. It's difficult to appreciate it on this video, but it really did help demarcate what was nodule and what was vagina, and it really also helped in terms of the suturing the vagina as well. We also find it, this is actually just from a couple of weeks ago, and again, not something that we included in the article, but in cases where you're struggling to put a colpotomy cup in, or if they've had multiple LETSs, it can be beneficial putting a little bit of ICG around the cervix, because it really does help demarcate the cervical vaginal junction so that it can aid dissection. Now, just last couple of slides. And this kind of ties into the paper that Flo just presented in terms of bowel DIE. We know that bowel surgery for DIE can be associated with significant morbidity, particularly if you get an ischemia and an anastomotic leak. And this is where I think ICG is fundamental, and where our colorectal colleagues have been using it for a number of years now, and it's certainly something that is standard practice for myself and my colorectal colleague. The evidence is quite clear, and there was a meta-analysis in 2020 that looked at over 4,000 patients, and that showed a significantly reduced leak rate in patients where intravenous ICG was used to assess bowel vascularity and guide your anastomotic line compared to when it wasn't used. So 3.8% with ICG compared to 7.8% without. And a further systematic review in 2024, which showed a 45% reduction in anastomotic leaks. There have been more studies done in the context of endometriosis. It was first described in 2018 for bowel resections for endometriosis, and Raimondo and colleagues in 2021 did a feasibility study looking at using ICG to guide their transection lines for both discoid and segmental resections in 32 patients, and they found that there were no adverse reactions to the ICG the assessment took on average 3 to 5 minutes, and there was excellent intraoperative agreement. And more recently, Burdell and colleagues have been actually using it to assess vascularity with regards to rectal shaving. And they found that it did guide their surgical practice, that if there were a particular area that didn't have as good a vascular supply, then they would reinforce that area. And again, it has the potential to reduce the risk of bowel complications and potentially improve safety. Oh gosh, apologies if you can hear the sound. I must have forgot to taken it off here, but you can just see here where we're using ICG to guide where our resection line is going to be. I'll skip through these ones just in the interest of time. So I think 2 or 3 more slides and then I'll hand back. These are just a few more novel uses of ICG where there's not as much data in the literature. There is some data around ovarian vascularity and whether or not we should be using ICG to guide oophorectomy versus conservative surgery in the context of torsion. And I think this is difficult because there is no standard guidance on how we assess ovarian torsion. But there was a study by Nicholson in 2022 that looked at 12 cases of ovarian torsion, and they also looked at preoperative Doppler blood flow, and they found that there was ICG fluorescence in 10 out of 12 detorted adnexa, even when the scans beforehand suggested there was absent Doppler flow. So there is evidence to suggest that using ICG might help guide whether or not you should remove an ovary or whether or not you should conserve it. And this is just a case actually only from 6-8 weeks ago now of an ovarian torsion. This is a young patient, so we were always planning to conserve her ovary, but you can see here the ICG clearly flowing through the IP ligament, and there is good vascularity to the ovary as well. Ureteric vascularity. This is really interesting and something that I've been doing a lot more of. There is evidence in the literature, and Raimondo and colleagues back in 2021 described utilising ICG, intravenous ICG, as a means of assessing ureteric vascularity after ureterolysis procedures on average it took around 5.4 minutes to assess ureters. And they found that it helped guide them better than white light assessment to whether or not there was a potential for a devascularization injury and whether or not they should place ureteric stents. So it may improve their intraoperative decision making. And finally, assessment of endometriotic lesions. And this is where there's exciting evidence, but the evidence is varied. There are some studies that seem to suggest that ICG might improve the detection of more occult lesions of endometriosis, and it might aid complete excision and recurrence. But as it stands, the largest review and the biggest meta-analysis in 2024 seems to suggest that there's not enough evidence to say that ICG is superior to white light in diagnostic accuracy. But it is something that I think there will be more data on in the future. So just to wrap up, I think when we looked at the data, there's not a huge amount of qualitative evidence out there with regards to randomized controlled trials around ICG, and we do need larger scale prospective studies and RCTs around its use. And there has been a recently launched ICE trial, which is looking at ICG versus ureteric stenting. So once we get the results of that will be really exciting as well. And we also need to look at the cost benefit analysis of ICG. The studies, unfortunately, are lacking in this. I'm just sharing with you the link again. And I think I've just kind of covered this already. Hopefully, with this article, I've highlighted that it is a helpful adjunct in minimally invasive surgery. It has a wide number of clinical applications, but as with most things that are novel, we do need more data out there, more RCTs, just to increase the evidence base and more definitive cost-benefit analysis before we fully implement it in standard non-cancer gynae surgery. Thank you very much. And just one final push. I'm sure everyone will be here, but I welcome you all to the ASM in May next year. I'm going to stop sharing now. Thank you.
Thanks very much, Rebecca. So yes, I think ICG has changed a lot of practices, and I agree with everything you said. And I think there will be lots of questions. I hope there will be time. Um, can I suggest that we just do our one remaining presentation, and then because we started 10 minutes late, maybe we can carry on for another 10 minutes after 7 and cover a couple of questions that has come from our colleagues from Turkey, Ahmed Kale and Tanesh Usta. And we can then have a little discussion about the ICG paper as well. So Avril, do you want to go?
Yes, thank you. So my paper is from the Nature Journal and recently published in October last month. And this was by a team from China, and the aim of their study was to identify the risk and protective factors for post-operative recurrence of deep infiltrating endometriosis. Next slide, please. So, methodology, they identified 320 patients who underwent surgery sorry, Oscar, the slide before, who underwent surgery at the first affiliated hospital of Sut Yat-sen University and diagnosed with DIE between January 2010 to June 2016. Inclusion criteria included operation performed laparoscopically, histological confirmation, complete clinical records and follow-up information to enable accurate data collection, duration of follow-up for at least 6 years. And during the follow-up, they perform a gynae exam and a transvaginal scan at 3, 6, and 12 months, and then yearly afterwards. And they also did a pain questionnaire with a 10-point VAS scale. What the team defined as recurrence is if anyone has a recurrence of pelvic pain after at least 3 months of remission after surgery, if there's any clinical findings such as a pelvic mass, pelvic tenderness, nodulations on examination, or if there's radiological findings of recurrence. Next paragraph. Next slide. So, over the 6 years of follow-up, they found that pain recurrence is 1.25%, cyst recurrence is 11.6%, and DIE lesion recurrence is 1.25%. And then below, it shows the cumulative recurrence rate over 6 to 12 years. So 6 years, 7.1, 7 years, 8.7%, 8 years, 11.6%, 9 and 10 years, 12.8%, 11 and 12 is 14.1%. Next paragraph. And they perform a univariate and multivariate analysis of the risk factors. So you can see the first circle that I've highlighted here on the left. It looks like advancing age at the surgery is protective for post-operative recurrence. On the right here, if you looked at the multivariate analysis, so the presence of left-sided endometrioma demonstrated the strongest association with increased recurrence risk. And then if you look below, GnRH and agonist for 6 months duration and a post-operative pregnancy also emerge as protective factors. Next paragraph. I haven't included this slide, but they did an ROC analysis and established that the age of 33.5 years was the optimal age threshold for recurrence prediction, with patients less than age 34 exhibit a 5-fold higher risk of recurrence. Next slide. This one is the Kaplan-Meier curve looking at the cumulative rates of recurrence based on the GnRH agonist usage. And the ones in blue, the one that is the highest, is the duration, is the patients who do not have any GnRH agonists, whereas the one in pink is those who receive 6 months, and the 6 months regime achieved the lowest recurrence rate, 8.23%, versus 27% in 3 months and 36% in the untreated group. And then the next slide. And then the next one is the Kaplan-Meier curve for rate of recurrence based on the site of endometrioma. So the left-sided endometrioma conferred the worst prognosis for cumulative recurrence, 47.4% versus 4.8 to 13.6 in the other group. So the conclusion of this study is left-sided endometrioma was an independent risk factor for the recurrence of deep infiltrating endometriosis. The authors suggest that during counseling, if this location is identified pre-surgery and the patient is not intending for a pregnancy, one could consider a unilateral or bilateral salpingo oophorectomy. I'm interested to hear what the panel think about that. Or those who have left-sided endometriomas should have more rigorous long-term management after surgery, such as having GnRH analogs, or those who wish to be pregnant should be encouraged to try to conceive afterwards. And then the second finding, as I mentioned, use of GnRH analogs for 6 months and post-operative pregnancy were protective factors against recurrence. And yes, that's all from me.
Avril, was this Lancet or Lancet Gynae?
This is Nature.
Nature, sorry. Nature or one of the things. It's an interesting paper for Nature to publish. It's very
nature.com//scientific reports.
Yeah, scientific reports. Okay, so it's Nature Group, but it's Nature Scientific Reports. That's what I thought. Nature tends to publish, different type of studies. It's very rare that they publish a surgical sort of
Finding.
non-RCT thing. That's what I thought. Still, an interesting, very long-term study. Yes, Mikey?
What do we think about the definition of recurrence? I think pain was one of them.
Yeah. And especially with like pelvic examination, like pelvic tenderness on examination, we know a lot of patients have like tenderness in the pouch of
Yeah, but you
Douglas.
could have muscular dysfunction. There could be some other driving factor. So how can you say that pain is a indication of recurrence, right?
It's a difficult one. I think for all of us, this is something that almost every patient who undergoes surgery will ask us, what is the risk of recurrence? And it's very difficult to answer that question because it depends on what we mean by recurrence. Do we mean what's the likelihood that you're going to end up needing another operation? Is it the question of, the effect on fertility? Are we talking about MRI or ultrasound recurrence? And each of those are different. I don't know. What do you guys say to the patients? Rebecca, what do you say to patients who ask, what's the risk of recurrence?
No, it's difficult. I think you've hit the nail on the head because it is what is recurrence. Because as Mikey alluded to, pain is very much multifactorial because it's setting the expectations of what do we think the pain is and what are the objectives if we're going down the route of surgery. But from a true endometriosis recurrence, I mean, the data is so variable, isn't it? 5 to kind of 60%. So I'm just honest in terms of this is what the data is, but pain is multifactorial and there may be other causes of the pain to recur, but it may not be a recurrence of endometriosis per se.
Okay. Let's deal with a couple of questions that were posted. Avril, do you want to take those questions?
Okay, the first question is from Professor Tanir Usta. I think it's more of a comment, who stated that hospital stay for about 5 days is too long for double discoid resection. What do people think?
So Tanner, the patient we operated on was done on, when was it, Oscar?
Last month.
Yeah.
Friday.
Yes. But I agree with you that, this was a special situation though, and the reason she stayed in was mostly nausea for whatever reason. But yes, there's really no reason for these patients to stay for more than 2-3 days. And if everything goes well, then they can. I think in different setups, it is done differently. There are surgeons who are, how would I put it, more traditional in the way of thinking, and they want to keep the patient until they've opened their bowels, they are eating and drinking normally. And actually, I understand the rationale behind that. And there are others who are very happy to send the patients home day one and with good backup plans, and get the patient to contact, and if there's a problem, or there's good support at home, or there's good nursing support. But I agree with you that on average, I think a 2 to 3 day would be more appropriate. And Professor Kale is talking about DCST. Now, this is the first time I'm using this acronym. DCST, double, what is it?
Circular
Circular
staple
staple.
technique.
Double
Doesn't
circular
roll off the
stapler
tongue.
technique. Okay. It doesn't, I don't know.
Doesn't flow.
Yes, I think they should have left that to the CMIC team to come up with
An acronym.
acronyms and things like so sure. We will come up with something. So if you compare segmental resection with DCST, what's the main difference between the two? Well, I don't know if the paper addressed that, but there are things that we can assume. There's less dissection, there's going to be less injury to the nervous structure around the bowel. You have a much shorter staple line, and therefore you would imagine that the risk of anastomosis leak may be shorter. Now, I should not say this. I certainly should not say this on an online thing that will then go and stay on YouTube. But I don't think we've ever had a leak from any disc resection. Ever. Am I saying it right? Correct me, Flo, Avril, you
You
would know
haven't.
the data well.
Not from a disc that I know of.
Yeah, so I don't know. We have had very good experience with the discs, and we've done a few double discs. I think probably 10, if I was to guess, double discs. And with all of them, we did a flexible sigmoidoscopy, and we also do all sorts of tests, bubble and ICG in the lumen. Which leads me to a comment I wanted to make about Rebecca's presentation, that the um, the thing to be careful about when you're using ICG in the lumen is that then you can't use the ICG intravenously afterwards for the same patient because your operating field is a little green or too green. Yes. I really like the ICG of Storts. I have to say I haven't worked with the other ones apart from the robot, but it really has a big advantage over the Firefly of the Da Vinci, and that is that you can actually operate while you've got the ICG on. Yeah.
Yeah,
Mikey,
no,
what do you think about ICG?
I like it. So at the list, we use it quite a lot. There was Rebecca. I don't know if you're aware, but there's a International Society of ICG. At that ESG, there was a lovely chap that spoke to me and Avril. Where was he from? Avril? From
He was
Brazil,
from
right?
Brazil.
So he had a really nice trick that we didn't use. Do you know what the green? I think it's a green apple that they use as a rectal manipulator. Okay, so
It's
essentially what
not
he
a
does.
real apple.
No, it's not.
It-
It's
it's
essentially
called apple.
so what he does his own version of it. So he put ICG on a swab and then puts a glove on it and places it directly for shapes. And that gives him actually quite a nice delineation of the nodule that he's excising. So that was a quite nice little trick that he showed us. Yeah.
Say that again, Mikey. So it dipped
So
it in the
So he takes a swab, dips it
yeah.
in ICG, puts it on a forceps, and then puts a glove on it. So the same thing that we do essentially when we're
Yeah.
doing hysterectomies,
Yeah,
etc.
yeah.
But he puts it in rectally, and when he does a shave, it sort of lights up the layers of the bowel quite nicely.
Yeah.
I thought you
Okay.
He
said
also put it in the
puts in
vagina
the
as well.
vagina.
Yeah, you
Yeah.
can put it in
Vaginal
the
nodules.
vagina as well. Yeah. So that
Mm.
was something that we've learned this year at the ESG.
Okay. And Marco Zakaria is asking Rebecca, whether you have any use for ICG in diffuse adenomyosis.
I think probably, I'm assuming in the context of maybe excision of an adenomyoma. Is that the question? Maybe
I'm
in
not
the
sure.
context, yeah, in the context of adenomyosis, I've not utilized it terribly much, but in the context of excision of an adenomyoma, very similar to when you're using it for fibroid, isn't it? Instill it into the uterine cavity, and it is really helpful because with a fibroid, you know, you've got those easy planes that it comes out, whereas with an adenomyoma, you can end up in places much more quickly than when you're doing
Yes.
fibroid dissection. So having that green visualization of the uterine cavities, it can be really, really helpful for an adenomyoma excision.
Okay. Well, wonderful. I think we need to wrap up. Thank you very much, Rebecca. It was lovely to have you. And please come back and contribute to the discussions. Yeah, we have a visitor here. And thank you, team. Again, Flo, the ex-Legendo boss. You are now the old news, Flo. I'm sorry. Yeah. And Avril, Mikey, Oscar. Avril, you were the boss, what, 2 years ago?
Yeah, I'm really
God,
old.
you are,
You really are.
yes,
Really,
you really are.
collecting dust in the corner.
And Mikey, our co-host, and Oscar, who's the new boss. Thank you to everyone, and I will see you on the 6th of December. I think we can announce that we can have Professor Fauconnier from Paris, and it's going to be a really exciting presentation. So please join us. And please, please, please tell your colleagues, tell your juniors to come and join us on the 6th of every month at 6. We promise not to be late again.